Well, good evening, everyone. My name's Paul Greenhalgh. I'm the CEO of South Gippsland Hospital here in Foster, in the beautiful South Gippsland Shire. And I'd like to welcome you all to tonight's community information session, and thank you for taking the time to have that line of curiosity to understand a bit more about the COVID-19 vaccination at many levels. So before we start, I'd like to acknowledge the traditional custodians of the lands on which we meet today and pay our respects to their elders past, present and emerging, and also extend our respect to Aboriginal and Torres Strait Island peoples today. Tonight we will hear from 4 highly qualified and esteemed panel members on the international perspective of COVID-19, the vaccination safety, regional and local responses. There will be absolutely an opportunity for questions at the conclusion of the presentation, which will take about 20 minutes, give or take. Please submit questions using the question and answer function. Most people will find that at the top taskbar of their Teams platform. Some may find it down the bottom depending on the device they're using. And we will endeavour to answer as many questions as possible during the live stream. To ensure we're able to answer as many as possible, please click the thumbs up icon to like a question when it becomes available. And if your query is similar, then obviously there's no need to resubmit a question, but that will help us prioritise the questions at the end of the session. We did receive some questions prior to the session, and thank you to those participants for doing that. And we hope to address those throughout the presentation. If you feel that your question hasn't been adequately answered, then of course, feel free to ask another question through the Q&A function. First speaker tonight is Priscilla Robinson, and and she will provide an update on the international perspective of the pandemic. Priscilla is a public health epidemiologist specialising in communicable diseases and international health. As associate professor at La Trobe University's Department of Public Health, she has been actively involved in public health research, while also supervising research students and teaching in Australia and developing countries. Since the start of the pandemic, Priscilla has studied COVID-19 rates of disease and immunisation around the world. Over to you, Priscilla.
Thank you, Paul, for this welcome, and good evening, everyone. Well, to kick off, COVID-19 is a new disease and the vaccines to prevent them are even newer, and it's reasonable to be nervous of both of these things. People develop immunity either through getting and recovering from an infectious disease or through immunisation, or occasionally both. For an infection to stop circulating, it has to find non-immune people to infect, and this is called herd immunity, about which we're starting to hear a bit. To stop COVID, at least 80% of all people have to have either had a disease and recover from it, or to be fully vaccinated. But let me backtrack a little. Since the start of the pandemic about 20 months ago, worldwide there have now been 222 million cases and more than 4.5 million deaths as a direct consequence of this disease. In some countries, more than 10% of their people have had COVID. In one country, that actually is 20%, 1 in 5 people. Thankfully, the fatality rate has fallen from 10% at the start of the pandemic to just over 2% we have now. Worldwide, although cases of all ages have been identified, most have so far occurred in adults, and men and women have been affected roughly equally. However, this isn't a systematic 1 in 10 people. Because of the way that COVID spreads, some groups of people have been very badly affected, and in some families and some groups of friends, the proportion of people that it has affected has just been everybody. Early on in the pandemic, people talked a lot about COVID reproduction rates, and I expect you remember them. There are certainly other diseases with higher reproduction rates, but mercifully they are well controlled here, such as measles with a reproduction rate of about 25. All the diseases never arrived on our shores, such as Ebola virus. However, having a low reproduction rate doesn't make it unimportant. The best estimated reproduction rate for COVID-19 in an unvaccinated and unexposed population is about 2.2, which means that for every person who picks it up, just over 2 people will become infected, who will go on each to pass it to 2 more people, repeated every couple of days of incubation. So one sick person becomes 1 plus the 2 they infect, who become 1 plus 2 plus 4, who become 1 plus 2 plus 4 plus 8. So in just over a week, that's about 15 people. And then it really starts to take off. But if the virus can't find a non-immune person to infect, it just dies out. Worldwide, this pattern has been consistent. And in places without containment measures, you know what containment measures are, they're masks, hand hygiene, social distancing, elbow bumps and so on, case numbers and deaths have been enormous. The USA, for example, with a population of about 330 million people, went from nothing in February last year to 10% by November. All viruses and bacteria change over time, some more quickly than others. That's why we need to have a new flu vaccination every winter, for example. There are now many variations on the original alpha strain of SARS-CoV-2, the virus that causes COVID-19. The most common variants are called Delta, which is the one you will have heard of, but there's also Beta, Gamma, Eta, Iota, Kappa, Lambda and Mu. Mostly, these have occurred in just 1 or 2 countries. Delta strain doesn't appear everywhere. The Delta strain does appear to be a little less likely to be fatal than other strains, but because it seems to have a higher reproduction rate, more people get it. Because we live on an island a long way from other countries with very few entry points, in Australia we've seen very few cases, mostly because of our pretty robust public health initiatives. Only a small proportion of people have become sick and a low proportion of cases have died, not least because we have an excellent hospital system. That means for most Australians, especially in places which have not been badly affected at all, like here in Gippsland, the possible disastrous effects of this disease are quite hard to understand because, excepting for a few news feeds, they're not visible. But this doesn't mean we can ignore it. Various nearby countries have had almost no cases until very recently, for example, Thailand and Vietnam and Fiji, where cases are now really starting to take off. We can see a similar effect in Australia with what is happening in New South Wales, the ACT, and to some extent here again in Victoria. This will happen because most people have not had COVID and have not developed their own antibodies, and the COVID-19 vaccination program has been slow to take off compared with most of the world. So herd immunity will be low until our vaccination rates are a lot higher. So let's look at what's happening with vaccination rollouts around the rest of the world. Worldwide, about 5.5 billion doses have now been given, and over 1/4 of the world's population is now fully vaccinated. Australian rates are nothing like as high as most developed countries, including all of Europe, Canada and North America, which have full vaccination rates of around 60 to 75%, which, when you add on the infection rates of about 10%, is very close to herd immunity, allowing some international travel to restart. However, although wealthier countries have managed to get COVID vaccinations well established, most less wealthy countries are having a much more difficult time accessing and delivering these vaccines. In the poorest countries, less than 2% have had any vaccine at all, and less than 1% is fully vaccinated. So their peoples are terribly at risk. Look at lots of those places are holiday destinations when we're all allowed to start travelling again. And those people need to be vaccinated at least as much as we need them to be vaccinated, or we pose a terrible risk to them. It's reasonable to be unsure about new technologies. I'm old enough to remember how fearful many people were of microwave ovens at first. Some people believed that they could send signals to outer space, or that they changed foods to cause some serious dietary problems. Some people used to think that mandatory seatbelts were more dangerous than not wearing them. In a crash, they might cut your head off. Lots of people were suspicious of early mobile phones and thought they might give us brain cancer, something which was the subject of extensive scientific research. It's not unreasonable to be wary of new technology. Medical scientists know that vaccinations are excellent at preventing diseases, but we also know that COVID vaccines are very new and have been developed very fast. Jim is going to tell you some more about all of that. And yes, COVID vaccines do cause some common side effects, as can any vaccine for any disease, such as feeling a bit off colour, having a sore arm, swollen glands, headache and so on. But if there were other significant after effects which were common, We would be seeing them by now amongst those billions of people all over the world who have been vaccinated over the last 9 months. Overall, many independent assessments tell us that serious side effects directly resulting from the vaccines are extremely rare. We know that COVID-19 is now circulating, and as national and international travel restrictions begin to relax, we're all going to be a bit more at risk of getting COVID. We also know that although vaccination does not completely prevent us getting it, the risk is very, very much lower, and the risk of dying almost completely stopped if we are vaccinated. Worldwide, 9 months since the first national vaccine programme started, we now know that about 1 in 50 people who gets COVID will die, compared with only 1 in about 500,000 people who get one of the various vaccines, as this slide shows. And that really is an enormous difference. Thank you.
Thank you, Priscilla. We'll now hear from Professor Jim Buttery on the vaccinations. Jim is an infectious diseases paediatrician and vaccine safety researcher. He is the Professor of Child Health Informatics at the University of Melbourne, based at the new Centre for Health Analytics, Melbourne's Children's Campus. He's Head of Epidemiology and Signal Detection of SafeVic, the Victorian Immunisation Safety Service. And he's also a member of the Global Vaccine Data Network Executive. Over to you, Jim.
Thanks very much, Paul. Could I have the next slide, please, Emma? Thanks. These are my declarations. Essentially, I've been involved over the years in many vaccine trials, and also I sit on safety monitoring boards for a variety of COVID vaccine trials, which I don't receive any payment for. Next slide, please. So these are essentially the vaccines which we either have now or will have soon in Australia against COVID-19. So all of these vaccines have gone through a trial process with the phase 3 trials, which are the largest trials that demonstrate, 1, whether the vaccine works, and 2, whether it's safe, have occurred in anywhere between 30 to 40,000 people for each vaccine. The vaccines that we're going to receive are largely divided into 3 groups. So there's the messenger RNA vaccine, or mRNA. The one we're using at the moment is the Pfizer vaccine, and the one which has been licensed and will be implemented in the next few weeks, mainly in pharmacies, is the Moderna vaccine, and they largely behave very similarly. Essentially what they do is they trick our cells into making the COVID spike protein, which our body then forms protection against. They don't integrate into our DNA at all, so there is no risk of change to our genetic material, although RNA is something that uses genetic machinery to make the spike protein. Both these mRNA vaccines are the vaccine of choice at the moment for everyone under 60 years of age. And what we know from both these vaccines is they give very high protection even after 1 dose, although 2 doses are recommended for longer lasting protection. Over on the right is the other vaccine which we're currently using, which is a viral vector vaccine, the AstraZeneca vaccine, which uses an adenovirus that carries the genetic code for the spike protein. And that vaccine, again, tricks our body into making the spike protein, which our immune system forms strong protection against. That's the vaccine we're using in the over 60s. It's also the vaccine I had. And although its overall protection initially is not quite as high, although it's extremely good, and it's very good against hospitalization or death, it now appears like the protection from that vaccine seems to last a bit longer. Again, it's 2 doses, separated by anywhere between 4 and 12 weeks. The third vaccine, which the government has purchased 51 million doses of, but hasn't arrived due to manufacturing problems, has also had extremely successful trials, not only in the United Kingdom, where the trials showed it had very high levels of protection, but also in South Africa with a more, if you like, resistant variant, and that also showed very high levels of protection. We think it's arriving in 2022, and this is a much more traditional style of vaccine. It's very similar in some ways to the way that the hepatitis B vaccine was built, except the protein it uses is the spike protein from the COVID virus. Could I have the next slide, please? The other thing to realise is that even massive trials with 40,000 people have this ability to pick up common side effects, and we've got a very good understanding of common side effects. They've also got the ability to pick up uncommon side effects. What they don't have the size to pick up is rare or very rare side effects. And that's the case for all drugs and vaccines. And that's what we use surveillance for once a vaccine or a medicine has been licensed, to make sure that we're looking for those carefully. And this is the system we use in Australia for that. So there's spontaneous surveillance where healthcare workers or the community report adverse events to reporting services. In Victoria, the Immunisation Safety Service, SAFIC, is the reporting service, and we report everything on to the TGA, which is the federal system. And there's really been a revolution during COVID in our technical ability to capture adverse events, look for them quickly and visualise them using new technology. Coupled with that is active surveillance, where rather than waiting for people to report adverse events, we go asking people. And those of you who've had family members get vaccinated may have seen them receive SMSs following the vaccine, essentially asking, have you received any side effect? And that system asks for side effects on day 3, day 8 and day 42 after vaccination, looking for both initial side effects but also delayed side effects. We're collaborating with our international colleagues, including the Global Vaccine Data Network, which is an international system largely based out of Auckland, where we're looking for specific adverse events of special interest to make sure that we can quantify the risk and inform the community. And then finally, a critical part of vaccine safety is making sure we've got the appropriate education and communication, as well as specific surveillance systems, for example, in aged care, to make sure in our most vulnerable populations, we're still picking up adverse events, as well as making sure that we've got optimal immunisation coverage there. Could I have the next slide, please? So many of you may have heard of the blood clot side effect related to the AstraZeneca vaccine, and that's real. It's a rare side effect, and it occurs at about 1 in every 40 to 50,000 people who get it. Below the age of 60, and the reason AstraZeneca is preferred above the age of 60, 1, this side effect is more common, and 2, this side effect, should occur, is more severe than if you're over 60. This is a graphic from the UK, which was put out by a Cambridge group. And essentially what it describes is in the UK setting when there's a low exposure risk, which correlates to probably higher than we're currently experiencing in Melbourne, and probably even higher than in Sydney. But nevertheless, the potential benefits of getting vaccinated on the left, which in this case is the number of intensive care admissions prevented, shows that in the younger age group, the risk of the side effect is slightly greater than the intensive care admission risk. But as you go up the age spectrum, the risk of disease massively outweighs the risk of getting vaccinated. Could I have the next slide, please? And very similarly, this is the risk that many people are concerned about more recently with the Pfizer vaccine, especially in young people. And so what we do know is that there's also a rare side effect with varying rates described, because we're still understanding it, but somewhere between about 20 to 40 cases per million doses, mainly in young males, mainly after the second dose of vaccine. And that's an inflammation of the heart or the tissue around the heart. So the heart, as you know, is a big muscle, and so we call it myocarditis. The tissue around the heart we call pericarditis if it gets inflamed. So as you can see, the top part is young females, the bottom part is young males. And as you can see, on the left is the number of hospital admissions that are prevented, and this is US data, which is clearly a higher risk of infection than Australian data. And in the dark blue is intensive care admissions prevented. So as you can see, the benefit of vaccination is far greater at all these age groups. But you can also see that the younger you go down, the more common this adverse event is, especially in young males. But nevertheless, even in the highest risk group, the benefit significantly outweighs the risk of myocarditis. Could I have the next slide, please? So clearly there's not time tonight to give you a whole run through on all of the safety aspects of these vaccines. But there's some outstanding resources that are available for Victorians and Australians to learn more about not only the vaccines, but also anything about vaccine safety. So the Melbourne Vaccine Education Centre, with the links there, has a lot of FAQs around COVID vaccines, as well as many other vaccines. And in addition to that, the bottom link you can see there is the weekly vaccine safety report for Victoria, where you can see the reports of the adverse events and how many reports we receive compared to the massive number of doses that are being administered. The second link, which has got also very good information around the COVID vaccines, is the Victorian Government Coronavirus website. And then finally, if you are looking for vaccine safety information on the internet, can I suggest you first go to the WHO site, which is called the Vaccine Safety Net. And what they do is they use their expertise to look at websites all around the world, and they give it a tick if that shows factual and reliable information. And the good news for Australia is that we've got several sites that have been approved by the WHO Vaccine Safety Net, and the list will be on the website there, as well as one in our neighbours in New Zealand. And I think that's my last slide. Thanks very much.
Great, thank you very much, Jim. Very, very interesting presentation indeed, and many useful sources of information. So we're now going to go to Annelies Titulaer to provide an update on the regional response, that being that of the Gippsland Regional Public Health Unit. So Annelies heads up the operations at the PHU. She's the operations manager. And as a registered nurse with a Masters of Public Health, Annelies is passionate about the need to adapt to the ever-changing climate of health and healthcare. She's motivated to identify how we can have more meaningful interactions for healthier communities. And so it's my pleasure to introduce into Annelies, and it's over to you. Thank you.
Thanks so much, Paul, and thank you so much to the panel tonight. Such a wonderful opportunity to be here with you all tonight, and thank you all for engaging in this conversation. Okay, so I'm speaking from the Gippsland Region Public Health Unit, as Paul so kindly introduced, and we're a relatively new unit for the state of Victoria. We're one of 9 across the state and very much set up in response to COVID-19, and we're hosted by Latrobe Regional Hospital. So whilst we're hosted and live out of Latrobe Regional Hospital, we're very fortunate to service the entire Gippsland region. Next slide, please. Thank you. So we're very much focused on stopping the spread, working with the local community and developing that expert leadership so that we can respond to COVID-19 as a community, and then using and leveraging all that information so that we can continually work together for longer term, stronger place-based approaches in terms of improving population health across the Gippsland community and to the state of Victoria as well. Next slide, please. So how are we doing this at the moment? So very much involved in the contact tracing and contact and case management across the state and locally, as well as contributing to the rollout of the COVID-19 vaccine across the Gippsland region. This was just a good infographic, I think, that builds upon the speakers before me tonight in terms of the roadmap of the COVID-19 vaccine, and recognising it's a long journey to the point of administration. I've been very honoured to be part of this journey, building up that workforce and developing those sites and contributing to those logistics, and including the safety aspects that have been reported tonight too, in terms of the monitoring and surveillance. It's been an amazing experience, and really proud of all the efforts and everyone involved for this opportunity to help stop the spread by being vaccinated. I think it's important to think about what the journey will be like when you do go to access your COVID vaccine, and regardless of whether you attend one of our COVID community clinics across the Gippsland region, a GP clinic and so forth, the process is going to be very similar. And I think it's important to note that booking an appointment is always the best way to guarantee access to a vaccine. It's really important in this era that we continue to QR code and to make sure that we're COVID safe before entering the health care provider. You'll then be checked into your appointment, make sure that you're vaccine ready, and have that conversation to make sure you're well informed around the vaccine that you're receiving, your individual circumstances, and that you're able to provide informed consent. Once you receive your vaccination, You then will be required to stay for observation for 15 to 30 minutes and plan that second dose to ensure that you've got that higher level of immunity as described by the panel members tonight. Thank you. There's been some conversation around eligibility, and I just want to acknowledge that has been quite tricky in terms of who's been eligible for the vaccine and when, and very much based on priority groups, which has been fantastic to get the vaccine to those that are more vulnerable and are at that higher risk of contracting COVID, such as healthcare workers and the like. It is a lot simpler at the moment in terms of Pfizer being the preferred vaccine for under 60-year-old cohorts and Astra for 60 years and over. However, I did just want to mention that the Pfizer vaccine is available for those that are 12 years and over with a special medical condition, and that's listed on the website. So I think it's really important to do your research in terms of what's the preferred vaccine for your age group and your individual circumstances. So in terms of how the access has been modelled within the Gippsland region, I think we've been really fortunate. We've had a really strong state and Commonwealth approach to access. We started in terms of the Gippsland Region Public Health Unit with an outreach model to those more vulnerable cohorts. We worked with the local health services across the region to set up sub-hubs to provide access to those high-risk workforces, as mentioned. And now we've seen the development of 9 community clinics across the Gippsland region. And I just wanted to mention that in addition to the community clinics that we're running, there's a really strong access point at GP, respiratory clinics and some pharmacies across the region as well. So I think we've got a really great access to the vaccine across the Gippsland region. In terms of those community clinics, I just thought it'd be a bit of a map to show everybody where those community clinics are. It is an open access system, so you can access the vaccine at any one of these community clinics, as well as the GP and respiratory clinics and other access points that I just mentioned earlier. In terms of, I don't know where the numbers have gone on that graph, but that's okay. In terms of what we've achieved together, and this is very much looking at the state-based system, so these community clinics that I was discussing, we have delivered over 81,000 across the Gippsland region, and I've just seen recently as well that the Gippsland Primary Health Network have identified over 150,000 to the region as well. So with the most recent figures, or from the 5th of September, that's a total of 64.8% of the Gippsland population have received at least one dose of the vaccine, and that we're at over 42% of the Gippsland population that are 15 years and over that have been vaccinated. So I think we're tracking really well as a region, and thank everyone for the contribution in this really great rate, but also recognise that we've still got some way to go, and really grateful to be in this opportunity to discuss any further questions to support people to access the vaccine. And lastly, similar to the speaker before me, I think it's really important to do your research, make sure that you're looking at the vaccine, make sure that you're well informed with your decision making, and recognise that we've got some really great opportunities with our COVID-19 vaccines. They're safe, effective, free, accessible, and I think that we're really fortunate to be in this position, considering how far in we are from the beginning of the pandemic. I've just put in an email address for us at the Gippsland Region Public Health Unit. If you do require any further information, you can follow us on Facebook, and I've just put up the phone number and web address for the community clinic vaccine bookings, as well as the Health Direct COVID-19 vaccine eligibility checker and the location finder. So some really great resources. Thank you so much for your time tonight.
That's great. Thank you, Annelies. And I ought to have mentioned to our attendees this evening that we will have the presentation available on the website South Gippsland Hospital at the conclusion of tonight's meeting. And I'm sure that the Foster Medical Centre will be keen to put it on their website as well. So if you wish to come back and check out those resources that are available and the contact details, they'll be available on the website. We're now going to look at a more local perspective, and Dr. Phil Worboys will be outlining what the Foster and Toora medical centres have been up to. Phil's a rural GP who has lived and worked in the Foster area since the 1990s. He's an associate of the Foster and Toora medical centres and has been its unofficial publicity spokesperson since the start of the pandemic some 18 months ago. He is now helping to coordinate the medical centre's COVID vaccine response. So thank you, Phil. Over to you. It seems like Phil's on mute still. We'll just get him off mute, and apologies for the slight delay. Thank you.
That might be better. Thanks, Paul. At Foster Medical Centre, we've been busy for over 6 months with COVID vaccinations. We've been basically sticking to the rollout and the eligibility criteria as set by the government on its website. We're now immunising everybody over the age of 16, offering Pfizer for under 60-year-olds, with 3 weeks between the Pfizer doses, and AstraZeneca for the over 60-year-olds, with now 6 weeks between AstraZeneca doses. That's a recent change. If patients who are under 60 want the AstraZeneca, we'll give it to them as long as they understand the relative risks of TTS as set out by Jim. But there really hasn't been a demand for that since the availability of Pfizer has increased. And we are not offering Pfizer to the over 60-year-olds. The good news is that we have both plenty of appointments and plenty of vaccines. Last Friday, we counted over 1,000 vaccines in the fridges, and we are immunising every day except Sundays. We are giving on average over 100 vaccines daily, and suspect that we will be continuing to do this for the foreseeable future. And we're doing okay. It's very difficult to get up-to-date rates of vaccinations as it is a combination of federal and state figures. But this slide from a week or two shows, shows that in Gippsland we're travelling pretty well in comparison with others. As you see here, we've got 4 of the top 5 postcodes in Gippsland. The most up-to-date figures I could obtain say that 68.6 people in South Gippsland have had their first dose now. It is a little easier to extract data for our own patients, as illustrated here. And these are patients who have attended the Foster Medical Centre 3 times or more in the past 2 years. So for our own patients, our vaccination rates are excellent. And this has only been possible due to a huge amount of work at the medical centre, from sourcing the vaccines. We now have a good supply when little was on demand, offer initially, to the receptionists who have managed so many appointments and fielded so many inquiries, and they really are the unsung heroes, to the tight band of nurses and doctors all working for a common cause. The reason for the good numbers are that we have noticed a real change in attitude. A few months back, this was the situation. Many were ready for vaccination, but there was a large cohort of vaccine hesitant people who just wanted to wait and see. And we got that in the consults all the time. And then there was a small group of anti-vaxxers. The diagram is really not to scale at all, as the anti-vaxxer group is much smaller than represented here. But now there's been a sizable shift in attitude, and the vaccine hesitant group is much smaller. People are ready and willing, and they're turning up in droves. And the small group of anti-vaxxers remain the same, and predictably will remain the same. What we are seeing on the ground is that people are getting vaccinated for 3 main reasons. Certainly, and especially for the older patients, the personal protection against COVID-19 is the most important. Then the idea of getting vaccinated to help protect our more vulnerable patients in the community and families, that's been around as a reason from the beginning and remains a strong reason. But we are seeing an increase in numbers of people lining up for their jab for more practical or pragmatic reasons. They know that they will need evidence of vaccination to turn up at events, to travel either interstate or overseas, or even get into certain businesses in the near future. And so they are getting vaccinated. Many of these are coming from that previous vaccine hesitant larger cohort. And the future? Well, who knows? There's lots of unknowns. We don't know what variants are around the corner. We don't know what boosters are going to be offered, or which ones and how often, and what happens to all the children. As we've heard, as of Monday, the 13th of September, we will have Pfizer available for children over the age of 12. We are glad that we are not in control of the macro medical picture and can concentrate our efforts on the micro local medical picture, having confidence in ATAGI and the TGA. We will continue to try to help people work through their concerns about getting vaccinated. We'll continue to educate, vaccinate and protect as well and as many as we can. We admit to being gently, collectively nervous of what may happen when lockdowns and restrictions are lifted, as they have to be. But we also know we are not alone in being anxious about that, and that we are part of a tremendous health system in Australia. Thank you.
Thank you very much, Phil. And congratulations to you and the Foster Medical Centre for your work you've been doing. Sorry, are you still going, Phil?
No.
No, thank you. To our attendees, I hope you found the presentation of use and informative. I know I certainly have. And if I can direct you to the published questions that are to the right of the screen, your screens, you ought to be able to see that Prof Buttery's been answering them, and Priscilla's replying to a post as well. But just to skip through them very quickly, we're looking at what signs should we look out for receiving a vaccine that might indicate an adverse reaction, and Jim's provided some commentary around the common side effects that one may experience sometime after the vaccination, whether it be the first or the second dose, depending on the vaccine that's administered. There's a more specific question around myocarditis and blood clots, and there's some detail there which Jim provided. In terms of safety for the AZ over 60s, Jim again's provided some commentary there. So Jim, I think your responses are very comprehensive and self-explanatory, and I'm hoping that the attendees tonight can see the answers. In terms of the 70%, so long as supply is there, we ought to be able to achieve that by the end of October as a state. And a couple of good links that Jim's provided in relation to myocarditis and the blood clots as to when we can understand the signs of those adverse rare events. Another question around waiting. If most of the population get vaccinated, what does that mean? And both Jim and Priscilla have made some comments there, and by all means, participants, please feel free to ask supplementary questions should you feel that these are not comprehensive enough. From my point of view, they seem to be addressing the questions posed, which is great. There's just one there around children under 16, so I'm not sure whether Jim or Priscilla or indeed Phil want to pick up one. So there's a question relating to children under 16 of healthcare workers and essential workers be eligible for the vaccine. Would they be prioritised? Anyone have any information about that?
I'm happy to have a first stab at it. So both the Pfizer and the Moderna vaccine, so the Pfizer vaccine for several weeks and the Moderna vaccine, I think either earlier this week or last week, have been approved by the TGA for children 12 and up. My understand, and I think Phil mentioned that vaccine will be available for 12 and up from September 13th from the clinic. And we're certainly expecting children 12 and up who are at extra risk of COVID disease, so people with underlying health conditions are eligible at the moment. And as Phil indicated, we're expecting all other children 12 and up to be eligible very soon. Currently, they're working their way through BCE students and other students as priority. And I think then they're heading down for the rest of the high school age group. Below the age of 12, we're still waiting on results from trials to know should we be using the same dose or should we be using a reduced dose, and that data is coming very rapidly, but we still don't have enough data around those vaccines to make a recommendation below the age of 12.
Great, thanks, Jim. Any other panel members wish to add anything to that answer that Jim's provided? No, great, thank you. There's a question from Deb, who works at the hospital actually in relation to mandating vaccinations for all healthcare workers. We're aware that those that work in residential aged care facilities will have to have a vaccination. Now, Priscilla's just added an answer to that, so if we take a moment to review that. So some health lawyers believe that vaccination will become mandated for all health and essential workers. In fact, it's important that staff do not become a risk for the people they care for. So we know that not having the flu vaccine is a risk for patients, and that's our general comment every year in relation to influenza virus. So watch this space, I guess, Deb, and thank you for your question. And then there's a question about the safety for people who've had Bell's palsy. Would anyone like to answer that, please?
So we know that Bell's palsy, before the vaccine program started, was considered an adverse event of special interest. And the problem we have with conditions like Bell's palsy is that it occurs anyway in the absence of any vaccine. And so what we have to figure out is it more common after vaccination than it is if you didn't have the vaccine? And that takes a while to figure out. At the moment, there've certainly been cases of Bell's palsy reported after both the AstraZeneca and the Pfizer vaccine. It does not appear in Victorian or national reporting yet that it appears to be at increased risk compared to what we would expect to occur anyway, if you like, the background rate. So we think that the vaccine is safe for folk that have previously had a Bell's palsy. We don't think it represents a risk of it recurring. And certainly I had Bell's palsy a couple of years ago and had no issues after the AstraZeneca vaccine that I had. Great, thanks, Jim.
There's a question around safety in pregnancy. I think Claire's picked that up. Is everyone comfortable that vaccinations are in fact safe for women? Yes, and there's lots of nods in the panel, so thank you. And then in relation to chemotherapy, Claire's answering that question. So I think that might be all the questions. However, a late one's just come in. Is there such a thing as medical reasons to not get vaccinated? That's the question I'm just publishing now. So we'll take this as our last question for the night. And just to repeat, is there such a thing as medical reasons to not get vaccinated?
I'm happy to have a stab at that. It's possible to have a medical reason not to be vaccinated with one particular vaccine, but with the range of vaccines we've got available, it's pretty much impossible to think of a reason why you couldn't receive one. Now, there will be folk that the vaccine won't work as well in, for example, people that have very suppressed immune systems, but that's not a safety problem. It's just the vaccines won't be as effective. And there's a tiny group of people, for example, that are allergic to a component in the Pfizer vaccine who have a very severe allergy, but those folk can almost always safely have the AstraZeneca vaccine. So essentially, we haven't come across a safety reason not to be able to have one or t'other of the vaccines. And also, even in that unbelievably rare circumstance, next year we'll have the Novavax available as well, which is completely different.
Many thanks, Jim. And in fact, I'll just make a correction that the replies are coming from Phil Worboys, not Claire. Phil's logged in as Claire tonight on her PC, so that's why it's come up as Claire. So thanks to you, Phil, for your response in relation to pregnancy. And also there's the response relating to chemotherapy. And so that's seems to be in relation to the specialist's timing. And I think we might leave it there. I just want to once again thank everyone for participating tonight, to our presenters, to Priscilla, to Jim, to Phil and to Annelies. Thank you for taking the time this evening. And to our attendees, I really appreciate you coming forward, listening to what's been presented, asking some questions, and please get vaccinated if you're on the fence. I hope that you see the benefits. Certainly, we all would like to get back out and have some freedoms and yeah, get this COVID behind us as soon as we can. So thank you once again, and I'll leave you to the rest of your evenings.